The last session today is bariatric surgery versus bariatric endoscopy for the treatment of obesity, which will be delivered by Professor Suthep Udomsawaengsup. He's currently Associate Professor of Surgery from Chulalongkorn University. He is a well-known surgeon who has a lot of experiences in bariatric treatment. And we are lucky today because Professor Suthep is here with us today. สวัสดีครับ Professor Suthep. Thank you
Thank
for
you very
joining
much.
us today. How are you today?
Yeah, I'm doing great. Thank you very much. Thank you, Rangsit, for the introduction. Thanks, Professor Ratagon and his team, the ASEAN Gastro 2021 committee for the invitation. Thank you, Rangsit.
We have a lot of online audiences today. So please, Professor Suthep.
Good to see all of you. Thank you again. And yes, in the interest of time, I would start my talk right now. Thank you very much.
Thank you.
Good afternoon, ladies and gentlemen. On behalf of Endoscopic Laparoscopic Surgery of Asia, ELSA, and Asia Pacific Metabolic and Bariatric Surgery Society, APMBWS, I would like to congratulate the ASEAN Gastro 2021. And also, I would like to thank the organizing committee for the invitation. My topic is bariatric surgery and bariatric endoscopy for the treatment of obesity. This is my talk. It would be started with the weight regulation, following by bariatric surgery and bariatric endoscopy. And I would touch a little bit for how to choose. Finally, some related issue will be discussed. Obese, as we are known, is that it related to several diseases, especially for gallstone, nephro, fatty liver, cirrhosis, and varices, and other diseases. These are related to obese. So the aim of the treatment is to control or to reduce the severity or to get rid of those diseases. So with all diseases, the treatment of obesity need to be in the multidisciplinary team, including surgeons and physicians, as well as the patient support group would be led by a group of patients. So the treatment will be successful with the big group of teamwork with the patient as a central to get the patient out of the problem, especially obese and those related diseases. For instance, for example, this is the multidisciplinary team, the Chula BMI, our multidisciplinary team. We started since 2007. Right now, we have more and more member of team. So metabolic and bariatric surgery, I would start it with this, how it works. So initially, we believe that the surgery to reduce the size of restrictive or combined with malabsorptive would be the principle of how it works. But what we have learned after having more and more experiences, you can see that not only the size or the absorption pathway, but also several signals from the stomach or intestine have been going to brain and to control weight. So we call this as the gut-brain axis. You can see from this slide that gut and brain has the communication, especially for food intake. You will see that with the ghrelin on your right side, ghrelin secreted from the fundus or the body of the stomach was sent into the brain, and that would increase the food intake. On the other way, GLP or PYY, those secreted from the lower part of the small intestine, when it's increasing or getting into brain, that will inhibit food intake. With this gut and brain axis, together with what we have believed that the carry in and carry out model. So when we reduce carry intake or increase the appendage, weight will be going down. But this phenomena will be not last for long because of the metabolic adaptation. If you have a look closer, you'll see that when we start controlling weight by reducing food intake, the weight will be going down. But with the adaptation, the basal energy rate will be reducing. Even the patient try to eat really less, but weight doesn't go down well. So we call this as the set point model, means that the body has been already set at one point of weight. If you would like to have the set point to be lower, we need to have something more effective to be done. For example, this is the role of bariatric surgery. You will see that we will move a set point from the very high weight to be what it nearly close to the ideal weight. So this is what we would discuss later on. We have learned that the metabolic and bariatric surgery is very beneficial to control weight and metabolic diseases. But anyway, it's also related to several potential complications. So that we do need the guideline. The first guideline and has been published in 1991 and it's still used up to now is the NIH consensus statement. You will see that BMI above 40 or above 35 with serious health problem linked to the obesity would be a candidate for a bariatric surgery. On the other side, here in Asia, we started half a decade after NIH. You can see that we started at the Asia Pacific Bariatric Surgery Group. Finally, we established the Asia Pacific Metabolic and Bariatric Surgery Society, APMBSS. And our indication is BMI above 37 or BMI more than 32 plus diabetes or two other significant obesity-related comorbidity. We're still using this one up to now. After that, you will see several guidelines being introduced globally. Now I will discuss about obesity treatment, focusing on bariatric surgery. This is a history timeline of the bariatric surgery. It started 53 years ago, half a century for the first bypass, which have been done by Professor Mason. It was the open gastric bypass, followed by VBG or vertical band gastroplasty in 1982. These operations have not been done for a long time because of the band erosion and also the gastroclastic fissure. In 1990, the adjustable gastric band has been started and it's been popularized for a decade. And finally, the popularity has been reduced because of the potential complication as well as the limited results as well. In 1994, the gastric bypass has been done by laparoscopy and become the standard of care for obesity for a long period of time. At that time, also for those who are very high BMI or very difficult to perform the long-wide gastric bypass, the mini gastric bypass also introduced in 1997. You can see that it's one anastomosis. Right now, it's been changed to one anastomosis gastric bypass or AGB. Here you come the 2007, the sleeve gastrectomy, where we remove the majority part of the stomach, make the stomach to be a tube, right? Have you seen? The sleeve gastrectomy has been popularized up to now. With the popularity using of the sleeve gastrectomy, we found that some of the patients need some more bypasses to be added. You can see that we call it sleeve plus, and those we will categorize as the new procedures. Here, what we can do for the sleeve plus, you see that bypasses that we added could be duodenal jejunal bypass, DJB, duodenal switch, the bipartition, SADI, single anastomosis duodenal ileal bypass, or loop DJB, proximal jejunal bypass, or duodenal ileal interposition procedure. All these are the new procedure and need to be more evidence-based to be supported. This is the utilization of bariatric surgery since 1990. You see that bypass has been popular for a long period of time until 2013, where the sleeve gastrectomy has become the most popular. We also see the peak of band. You see it started in 2000, then peak was in 2007. After that, the utilization has been decreased, and right now it's really uncommon to have these band to be placed. Now I'll come to touch a little bit about bariatric endoscopy, which I guess most of you has been very familiarized, and some of you already have done or more experience than our bariatric surgery. So I would talk about the intergastric balloon. The other common and very popular would be the endoscopic sleeve gastroplasty. So let's see for the result. This is a study to be comparing intergastric balloon versus the endoscopic sleeve gastroplasty, a systemic review and meta-analysis. You will see from the BMI for your notice is that endoscopic sleeve has BMI of 36. The intergastric balloon has a BMI as average as 41. So what we have seen, you will see that from 6 months, it's giving a very good result, 15% for endoscopic sleeve and 12% for intergastric balloon. But we have found when we follow long term for endoscopic sleeve gastroplasty, giving the weight loss or can present the long-term maintenance. For balloon, you will see that after the balloon has removed, weight will be regained. On the other hand, the percent of excess weight loss, you will see that endoscopic sleeve giving a very impressive result. But anyway, to be noticed is that the BMI at the beginning is lower in the endoscopic sleeve gastroplasty group. We have to talk about the complication. You will see that for endoscopic sleeve, about half of the patient would have some degree of an abdominal pain, but for intergastric balloon, more than half of the patient would have a symptom of nausea. This is the complication that related to the procedure. Once again, this is the efficacy and safety of the endoscopic sleeve, the meta-analysis. So you can see that most of the study would have some size of the cohort, and the MI would be around 33 to 43. What we have seen is have a look closer in the endoscopic sleeve gastroplasty. You will see that the weight will be maintained even for long term. And you can see that the average after 2 years would be 17% of total weight loss, which very impressive too. This also to show the percent of total weight loss as the blue line, also the percent of excess weight loss has been maintained. This is we have talked about bariatric surgery as well as the bariatric endoscopy, but how to choose. I started with the bariatric surgery. You will see that the most common to be choose would be sleeve gastrectomy, not only because it seemed to be easier, but because of the patient themselves would be not too difficult to adjust themselves to maintain their life. So sleeve gastrectomy has become the most popular for almost all cases. But we reserve the long-wide gastric bypass for those BMI higher than 50. This is our central of the excellent preference, or the patient would have the higher hernia with the significant esophagitis, or those who have severe metabolic diseases. And this specific group of patients, we would offer the long-wide gastric bypass, or if we would like to do the sleeve, we would do a sleeve plus for this group of patients. To be emphasized that for those who would like to choose a long-wide gastric bypass, they need to be followed regularly. This is very important to prevent the potential of the nutritional or metabolic deficiency. Next would be some other issue that I would like to discuss. So the indication or the guidelines being published, and you will see that we have a big number of the patients who are already a candidate. But if you have a look here, globally, we can do only 0.1% of those candidates who would have the operation. In Asia, except Taiwan and Singapore, you will see that most of the country would be behind the average. In Thailand, we can do only 0.01%. And then you can see that this is the opportunity for us to give the care to our obese patient. In Thailand, at least 10 times to reach the average, but the average is just 0.1%. The question is how to get the bariatric surgery or bariatric endoscopy to be accepted or to be given to those who need. So this is what the environment of the bariatric surgery and all any factors, any part would be very important. Started with the bariatric surgeons, bariatric physician, the patient and family. The public awareness is very important too. Finally, for the payer, also very important. This is what we have done. You will see that for bariatric surgeons, we have a hands-on workshop 3-4 times a year to provide the bariatric surgeon to the society. For the physicians, we also have the multidisciplinary meeting or conferences. You can see that we also have the APBSS 2014. Public awareness, I would emphasize that is very important. So we have done all aspects for prevention, for the indication, also for the treatment or after treatment care. And patient and family, they have to have the information, and they do need to be part of the decision making and part of the successful of the treatment of the patient. Last but very important would be the payer. Let me share a little bit here in Thailand. This is the chronological development on the health insurance system in Thailand. We have 3 sectors. The first 5 million people are the government employee, following by 14 million of people who are in the private sector employee. The biggest group would be 49 million people who are the universal coverage. So we've been focusing on this group for the initiation of the reimbursement for bariatric surgery. Any people are eligible to buy the private health insurance for themselves too. We have the cost effectiveness evaluation for the bariatric surgery in Thailand has been published. And also to have the reimbursement to be done, we need to have our local guideline for the bariatric surgery. With all the information, we submitted the information to the National Office of the Health and Security. And finally, we have the reimbursement for bariatric surgery and metabolic surgery in Thailand to be approved since the 1st of April 2021, and it already been effective since the 1st of October 2021 under the peer authorization system. Ladies and gentlemen, this is my conclusion. The obesity and metabolic diseases are increasing. Gut-brain axis is a regulator of the appetite, weight, and metabolism. Multidisciplinary team and multimodality approaches are crucial for the treatment of obese. Bariatric surgery is strongly approved and advised if the patient are indicated. Bariatric endoscopy provides an impressive outcome and should be advised for those who are not the indication for bariatric surgery or not eligible for surgery. Factors may provide the better predictor of the result, and we still need the higher study level. Ladies and gentlemen, on behalf of Asia Pacific Metabolic and Bariatric Surgery Society, I would like to invite all of you to Rayong, Thailand for the APMBMS 2023. Rayong is located on the east coast of Thailand. It's suitable for sea, sand, and sunlight, but importantly, science will be discussed at Rayong, Thailand in 2023. Thank you very much.